So we'll be discussing the pediatric acute respiratory distress PALICC-2 criteria. Okay, so PALICC-2 was released in 2023. Before that, we had the PALICC-1 guidelines. Now, there are some subtle changes in PALICC-2. Let us discuss the definition first. Okay, so the definition and diagnosis. The definition criteria. It involves the symptoms of hypoxemia and radiographic changes must occur within 7 days of a known clinical insult. The diagnosis is based on oxygenation indices. If the patient is on invasive mechanical ventilation, then the OI, the oxygenation index, should be more than equal to 4, or the oxygen saturation index should be more than equal to 5. And if the non-invasive ventilation is being applied, or the patient is on high flow nasal cannula HFNC, then the PF ratio should be less than 300, or the SF ratio should be less than equal to 250. Okay, so it is less than equal to 300, or SF ratio less than equal to 250. Okay, so before going further, let us revise the oxygenation index formula. So oxygenation index, let me write here. Oxygenation index OI is equal to, we can remember it as M F by P. So what does this stand for? M is the MAP, F is FiO2, and P is the PaO2. Okay. OSI, the only difference will be instead of PaO2, we'll be using the SpO2. Okay. So OSI is equal to MAP into FiO2 divided by SpO2. Okay, so imaging findings. The second definition criteria: new unilateral or bilateral. Okay, not only bilateral, we have included unilateral as well as bilateral opacities on chest imaging consistent with acute parenchymal disease, excluding atelectasis or effusion. Okay, not including atelectasis or effusion. Stratification of severity. In case of PALICC-1, we had OI divisions like 4, 8, 16, like that. But in PALICC-2, mild to moderate PARDS is defined as if the patient is on IMV, then it is OI less than 16 or OSI less than 12. And if the patient is on NIV or HFNC, we'll be using the PF ratio and SF ratio, which will be PF ratio more than 100 or SF ratio more than 150. Okay. Now, in case of severe PARDS, see, we have to remember only 16 and 12, these two values, okay, for IMV people. So, severe, it just becomes OI more than equal to 16 and OSI more than equal to 12. And if the patient is on NIV or HFNC, then the PF ratio would be less than equal to 100 and SF ratio less than equal to 150. So, we can say that it is a bit more simplified than PALICC-1. Okay, so after definition and diagnostic criteria are over, let us go to the ventilation strategies. And there are two types of ventilation recommendations. One is invasive, another one is non-invasive. And we have to aim for lung protective ventilation. Okay, so what are the strategies in lung protective ventilation? The tidal volume, it should be 6 to 8 ml per kg. And lower volumes, 4 to 6 ml per kg, may be used cautiously. Plateau pressures would be less than equal to 28 and driving pressure would be less than equal to 15. So the plateau pressure would be less than equal to 28 and the driving pressure would be less than equal to 15. What about the positive end expiratory pressure? PEEP should be titrated to optimize oxygenation, hemodynamics, and lung compliance. Okay, so we haven't really gone for the PEEP minimum and maximum values, but we can recommend that it should be kept between 10 to 15 centimeter water, which was also in PALICC-1, and then we should titrate. In severe PARDS, more than 15 centimeter water PEEP can be used, but watch for plateau pressure. Okay, so we can like keep it between 10 to 15 centimeter water. Okay. So another new modality is high frequency oscillatory ventilation. It may be considered when conventional methods fail to meet ventilation goals. Okay, now coming to the non-invasive ventilation. For mild to moderate PARDS, we will be going for NIV and HFNC. Okay, not for severe PARDS. Severe PARDS will be needing invasive ventilation. So we have NIV and HFNC for mild moderate PARDS. Okay, but if the patient is not improving within 6 hours of NIV or HFNC, we should promptly revert to early transition to IMV. Okay. Now, the adjunctive pulmonary therapies which are recommended are prone positioning. Now, it can be considered in hypoxemic patients with inadequate response to standard measures. What about inhaled nitric oxide, INO? Recommended only for patients with pulmonary hypertension or right ventricular dysfunction. Okay. Surfactant therapy, the routine use is not recommended, may be considered only in specific populations. Let's come to the non-pulmonary management. Fluid and hemodynamic management is of utmost importance. Conservative fluid strategies are recommended to avoid fluid overload. Diuretics may be used if fluid overload is contributing to worsening oxygenation. So we have conservative fluid strategies and diuretics in case of fluid overload. Okay. Now, minimal sedation to be used to facilitate lung protective ventilation and to minimize asynchrony. And neuromuscular blockade only in severe cases where protective ventilation cannot be achieved with sedation alone. So first we'll be going only for sedation. Even if that is not working, asynchrony is still present, then go for neuromuscular blockade. Nutrition. Early initiation of enteral nutrition within 72 hours is recommended. Okay. With a preferable protein intake, minimum amount should be 1.5 gram per kg per day. Advanced therapies, ECMO, indicated for refractory PARDS not responding to optimal conventional therapies. And monitoring, continuous monitoring of ventilator settings, oxygenation indices, respiratory mechanism is recommended, and avoid prolonged hypoxemia or hyperoxia. So the preferred SpO2 range is 88 to 97%. Follow-up and long-term outcomes. Early post-discharge screening for physical, neurocognitive, and emotional deficits is essential. Pulmonary function should be evaluated within 3 months of discharge with spirometry for age-appropriate patients. That is spirometry for more than 6 to 7 years old patients.